Bismillah ar-Rahman ar-Rahim. Inshallah, today we are trying to cover three topics. Two of them are actually small topics. They will not take much time. Abnormalities of amniotic fluid or liquor and the decreased fetal fix. I think the biggest topic today is intrauterine fetal death, which is actually very important, and it's difficult issue actually, difficult to tell the patient, difficult to find the cause, difficult to manage. So it's an important topic for us, inshallah. Regarding the abnormalities of liquor, it can be, I think all of you know that it can be either oligo or polyhydramnios, but we will try to cover it from many aspects. First, the basic knowledge about the amniotic fluid, which is the sources. And I think all of you know that the source is filtration from maternal plasma. This is a common source in the first trimester. Then it is filtration through the fetal skin, and which is important to us after 16 or 20 weeks, which is mainly from the kidneys. It is actually fetal urine. And about 1/3 or 1/4 of the amniotic fluid comes from the lung secretions. And this is actually the most important to know, because we actually not give importance to amniotic fluid as early or earlier than 16 or 20 weeks. And in most of cases, if it happens to have oligohydramnios, it will be for rupture of membrane before that age, or it happens before that age, it will result in a catastrophic condition to the baby. And we will discuss it later on, inshallah. Now, we can see from this slide the amount of amniotic fluid, which is actually it's variable from 1 to 1. And to actually give more accurate data, we need to draw percentiles, and we can describe most of people between the 10th and 90th percentile. But it's generally, we can find that the amount of amniotic fluid, it's going to increase through labor, through the pregnancy, and it reaches its maximum or plateauing at about 36 weeks. And then it's it decreases. It decreases, but in a small or in a slow manner. Okay, I think this is better to explain that we need to draw the 10th and 90th percentile, because it's more relevant or more accurate when are describing all the population. And we will not describe abnormalities except if we find that the amount of liquor is above or below, is above the 90th percentile or below the 10th percentile. Okay. And it's actually, to be more relevant, we need to give it in 5th and 95th percentile, not the 10th and 90th, because this was found to be associated with more problems. Generally, when we speak about the small for gestational age or large for gestational age, we usually speak about the 10s and 90s. But regarding the LICOR, we find that even from 10s to 5ths, there is no problems in most of pregnancies. And also from 90s to 95ths, there is also no problem. So we will describe the abnormality if the amount of amniotic fluid is, as an oligohydramnios, the amniotic fluid is below the 5th centile, or in polyhydramnios if it is above the 95th percentile. And to we cannot actually do it, or we cannot draw the 10th and 90th percentile as for the amount, and we measure it objectively. So we need to have one or more parameter, clinical or ultrasound parameters, to express the normality or to express the amount of LICOR. It is not the actual measure for the LICOR, but it can express or it can give us idea about the amount of amniotic fluid. Okay, and actually we have one of two measures. Okay, we can either, one of the measures is to divide the abdomen into 4 quadrants, and we will try to measure the amniotic fluid, the deep vertical or the vertical dimension for each quadrant, here, 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 and calculate this calculate these dimensions, which is called amniotic fluid index. Amniotic fluid index. This is one method to measure or to express the amount of amniotic fluid. Another measure is to see which is the deepest part in the 4 quadrants. We can find this and this in the same patient, but this is more wide or more deep. So we will take this, and this is called deepest vertical pool. Deepest vertical pool. So we can use either of both measures. But we have more accumulating data that when we use the deep or the deepest vertical pool to express the amount of LICOR, we find that there is less intervention based on it. Okay, so it's recommended to use it more than the amniotic fluid index, but it is not relevant to stick to one of them, no problem. Okay, and usually we define polyhydramnios when we find that the amniotic, the deepest vertical pool is beyond 8 centimeters. Okay, it's beyond 8 centimeters, and the amniotic fluid index is beyond 25 centimeters. Okay, and we describe oligohydramnios when we find that the deepest vertical pool is less than 2 centimeters or the amniotic fluid index less than 5 centimeters. Okay. There is non-cycle to the amniotic fluid. We know that it's formed through most of it formed from the kidneys, as you know. Okay. Here's the fetus. Okay. It's formed through the fetal urine. Okay. And or through the part of it through the lung, as you know, lung secretion. But what will happen to this amniotic fluid? The baby will swallow this, okay, and it goes through the GIT. It goes through the GIT, and the amniotic fluid will be absorbed through the small intestine, okay, and it will go through the blood, and then it is secreted by the fetal urine, and this is a cycle of the amniotic fluid. Okay, this is a cycle of amniotic fluid, and from this cycle we can know what are the congenital malformations that can cause polyhydramnios or oligohydramnios, and we will discuss it later. Now, what is the function of amniotic fluid? Is there any function to amniotic fluid? I think it's easy, and all of you know many functions, but the most important function is to permit fetal movement. Without having this fluid around the baby cannot move freely. Imagine that the uterus without life. What will happen to the baby? The baby is compressed totally with the uterus. Okay, it can be like this on it. The uterus is molded on it. How can the baby develops the muscles and can move freely? It's different when there is all of this is life around him. Okay, it can move, and this will allow the development of musculoskeletal system. Okay, so it's very important to develop the musculoskeletal system. And sometimes with having oligohydramnios, there may be like bands between the amniotic membrane, and this can cause amputation, limb amputation or fingers amputation. So this is very important for the development of musculoskeletal system, and also the amount of liquor can give a chance to lung to expand, and this liquor also goes through the lung to maintain the alveoli open. So this will allow the development of pulmonary system. So without having a proper amount of amniotic fluid, there is no chest movement, no space to make the lung expansion. So there will be pulmonary hypoplasia, which can be fatal to the baby postpartum. Okay, and this needs to happen very early to cause this problem, because when it happens, there is the amount of liquor is low, for example, after 30 weeks, the lung has developed, and or the greater part of it has been developed. Okay. Also, when we find a preterm, not extreme preterm, even when we have drained liquor before 24 weeks or before 20 weeks, when it is below 20 weeks, the condition is very poor, and the prognosis of this pregnancy is very poor. Okay. when it's below 16 weeks, it's يعني there is no chance to have a healthy baby, okay, or the pregnancy to continue to term, or even to have a living baby, neonatal baby, for example, okay. So another minor actions like maintain body temperature, protect trauma, these are all minor effects. Protects cord from compression, especially during labor, okay, no problem. Oligohydramnios, we can describe if either the amniotic fluid index below 5 or the deepest vertical ball is below 2. Now, what are the causes of oligohydramnios? I need to hear from Dr. Abir, what are the most common cause of oligohydramnios? Dr. Abir? Okay, Dr. Islam? What is the most common cause of oligohydramnios?
Rupture of membrane.
Rupture. Renal anomalies?
This is the most common? Okay. I will tell you, I will give you 5 options, and please choose the best correct one. Okay. Idiopathic, rupture of membranes, renal agenesis, congenital polycystic kidneys, IGR.
Idiopathic. Idiopathic most common.
Okay. The next question, esophageal atresia will cause rupture, will cause oligohydramnios. Some of you.
No, polyhydramnios.
Exactly.
Polyhydramnios.
Okay. And regarding the polyhydramnios, I will give you what is the most common cause of polyhydramnios. I will give you only or also 5 answers to choose the best of them. The first one is esophageal atresia, maternal diabetes, idiopathic, posterior urethral valve. Okay. What is the best answer for polyhydramnios?
Idiopathic في الحالتين.
Okay. Idiopathic for polyhydramnios, but for oligohydramnios, the most common is preterm, pre-labor rupture of membrane. Idiopathic is actually less common. Okay, sometimes we can find idiopathic. We cannot find any cause for oligohydramnios, but this is is not actually common. Okay, we can find the pre-term labor rupture of membrane is a cause. Renal agenesis can be so. This is responsible about more than half of the cases. Okay, renal agenesis, polycystic kidney, congenital polycystic kidney, obstructive uropathy, posterior urethral valve, placental insufficiency, genetic chromosomal anomalies can happen. Okay, viral infections, which is more common to cause polyhydramnios, and also chromosomal abnormalities is more common to cause polyhydramnios, but sometimes it can cause oligohydramnios. Okay, so these are the causes of oligohydramnios. Yes, 20-20 transfusion can be a cause for one of the babies to have oligohydramnios and the other is polyhydramnios. Okay. We need to, inshallah, we can take twins next time. Okay. What are the complications of oligohydramnios? Okay. Is there any complications for oligohydramnios? for sure, don't forget the cause of oligohydramnios as the cause can cause a complication. Okay, not only the oligohydramnios. So it can cause deformities. Oligohydramnios itself can cause deformities. Bohty syndrome, which is described for renal agenesis. Why it is described for renal agenesis? Because renal agenesis cause actually a severe oligohydramnios, and it will start very early. It is oligohydramnios from 16 weeks, or it starts from 16 weeks. So it will affect the development of the lung and the musculoskeletal system, and also the face of the baby. So you will find in Bohty's facial dysmorphosis and pulmonary hypoplasia, and sometimes amniotic bands, which cause amputations, in addition to skeletal hypoplasia. But we usually, when we have another cause for an early oligohydramnios, we call it pseudo-Bohty's, or sometimes Bohty's. Also, oligohydramnios can cause malpresentations, fetal distress during labor. Prematurity also can be a cause for or a consequence of rupture of membrane, for example. Okay. Maternal, there may be increased interventions which can cause increased morbidity, or and also for rupture of membrane, for example, it can cause infections or complications that affect the lung. Okay. Before going to this slide, what are the when you are faced with a case with oligohydramnios, what's your management? Okay. Is it common? Is it common in your practice to see oligohydramnios?
Yes.
Who will tell me what's your management for oligohydramnios? Okay. Dr. Rasha? Dr. Rasha, can you tell me?
Excuse me, could you please repeat the question?
I cannot hear you well. Okay, no problem. Dr. Iman? Okay, what you need to do is
assessment in the company.
Okay.
History.
You need to do assessment, which includes history, examination, investigation sometimes, and according to the cause, according to the gestational age, according to many things, we will do the management. History, we need to know exactly the presentation of the patient, because actually in UK we are not doing regular scans after 20 weeks in low risk patients. We usually not to follow with the scan. So we are protected from many conditions that we are facing in Egypt that with regular scans we find, oh, the liquor is decreasing. It's 6 centimeter, it's 5 centimeter, it's become 7, but it returns again to 6, but it's now 4. Next scan, and this will cause maternal worries. Huh? Okay, so it can cause maternal worries and doctor worries also. Okay, so in UK, this will not be the case, but we will find association. We will find sudden gush of water, so it's most probably it's rupture of membrane, and we will do the assessment of rupture of membrane. Okay, we can find it during the follow-up for a high-risk pregnancy and the liquor is low, and we need to ask about history of passing or of vaginal loss of liquor. Okay, for example, so rupture of membrane is a very important cause. We need to exclude it for any case with rupture of membrane by taking proper history, by doing cascospiculum, and we can also check if she has symptoms or if we are not, she has symptoms but we are not, the examination is not conclusive for rupture of membrane to do a scan, for example. Okay, and for also we can find a case with small for gestational age by the fundal level is below average, and this can trigger doing scan, and we can find the oligohydramnios, really oligohydramnios, and we can find search for some anomalies, or we can find it during the anomaly scan from the start. Okay, so during the assessment we need to check history, doing the examination, seeing ultrasound, and doing objective assessment of the liquor. See fetal size, because it can be due to it is associated with a small baby, so it is a sign for or it is a consequences of placental insufficiency. Revised fetal anatomy, okay, can be due to renal agenesis, obstructive urology. The problem during oligohydramnios that you may not be able to do a proper anatomy scan, okay, because the liquor is important to see the baby in a proper way. We can do Doppler. We can request karyotyping if you see some stigma of chromosomal abnormalities. This is not actually a usual procedure to do amnio inclusion to have a better view for fetal anatomy. This is, please remove it, better than to leave it. So I will remove it actually. Okay. What is the prognosis? The main determination of the prognosis is the cause, gestational age. Okay, so these are the most determined for the prognosis: the cause and the gestational age. And the gestational age can be very critical, especially if it happens during the second trimester or before 20 weeks. There is a high chance of poor perinatal outcome, okay, especially if there is a cause like renal agenesis. This is incompatible with life actually, okay, and the pulmonary hypoplasia will occur. if we can, well, this is important during counseling the patient. We can find that for gestational age at 20 weeks or 21 weeks, the possibility of pulmonary hypoplasia is 90%. When you go less than this gestational age, the possibility of pulmonary hypoplasia is more and more. Okay, but at 25 weeks, it's about only 50%. At 29 weeks, it's about 10%. Investigations. What is the recommended investigations? It depends on the cause. Okay, if it is rupture of membranes, so we need to do what we need to do in rupture of membranes laboratory. We can
TBC, C-reactive protein.
complete blood count,
yes
C-reactive protein.
marker of infections. Yes. Okay. Do we need to do prenatal ultrasound? Okay. In most of cases, we will not do ultrasound to see the liquor. Okay. Especially in gestational age after 25 weeks. Some people, I know that some people, we do frequent scans to see the remaining glycan. It is not important because the liquor is actually we will continue. We can do for case of rupture of membrane, if it is if the gestational age is beyond 28 weeks, we can do frequent CTG to assess the fetal well-being. Okay. We can do postnatal evaluation. We can keep the baby under observation because the risk of infection, to monitor for infection, for example. So another cause that can be renal, or we don't have rupture of membrane. We need to search for the cause. We can find that there is no kidneys. Okay, for example, this can be the cause. Or we can find obstructive uropathy, for example. We can find obstructive uropathy like in posterior urethral valve, which happens in male or female babies? In?
Male.
Male, exactly.
Male.
In this case, I diagnosed this one case with posterior valve. I suspected it very early. I did the scan for her at 15 weeks, and I found a cystic mass inside the pelvis. A cystic mass inside the pelvis, and I referred her to one of my colleagues who works in the fetal medicine. He actually told her to repeat the scan after 2 weeks, which revealed this mass or this cyst becomes larger. Okay, and it starts also the ureters to appear. Okay, so it becomes apparent that it is an obstruction in the urethra. Okay, and you can find in later, if you wait, you can find or you can see the dilated kidney. It will happen. It will happen. There is no without intervention. Okay. So, what do you need to do for this baby?
Shunt. I want to introduce a shunt between the bladder and the amniotic fluid.
Okay. you need to drain this this fluid, and the best is to drain it to the amniotic fluid, okay? Because by this way you will treat oligohydramnios. So you will save the kidneys from damage of back pressure. On the same way, you will treat or you will prevent the complications of oligohydramnios on the baby to develop. Okay. We can insert a pigtail caster, and this pigtail between the urinary bladder and the amniotic fluid, which is called zygoamniotic shunt, and this decreases the complication of this condition in many cases, but it is not. It needs an expert actually, and for this case actually it fails, because insertion, the accurate insertion to be between the in the right place can be a difficult issue. Okay. So this is the investigations, which depends on from case to case. From if you have a suspicion of chromosomal abnormalities, you need to do karyotype. Okay. And the management also, it depends on the case, and also the intrapartum care can be different from a cause to another cause, for example, and also neonatal care. Okay. Here is a picture of stereourethral valve and its effect on the kidneys, and we need to do zygoamniotic shunt. Okay. For many or for most of congenital malformations, when you are going to do intervention, it's better to check the karyotype, because sometimes, especially if you have any suspicion about the karyotype. Okay, because you are going to do an intervention, and this intervention, if there is another congenital malformation, or if there is abnormal karyotype, this intervention will not save the baby, and it can do some complications for the mother. Okay. Okay. This is just a help for you to, especially when you find oligohydramnios at term. Okay, you need to exclude the rupture of membrane. You need to review the dating of the patient. You need to exclude especially the gross restriction. Okay. Maternal disease that need delivery of the baby, like hypertension, for example. Diabetes usually causes polyhydramnios, but sometimes if there is associated IUGR, it can cause oligohydramnios. So if you find an indication to deliver the woman, deliver the woman. If you don't find any cause of for these oligohydramnios, and you didn't find and you consider this idiopathic oligohydramnios, what will you do? What's your opinion? If you find a case with the liquor is below 5 centimeter, 4 centimeter, for example, and the gestational age is 38 weeks, what will you do? Do you have any suggestion
Reduction of labor.
immediately?
اشوف بقيت
Reduction of labor.
يعني الفيتال موفمنت كويسه ولا لا، هي عندها اي ريسك فاكتور، ما عندهاش اي ريسك فاكتور، وهي كويسه وده جيوباستيك. هعملها ري اسسمنت بعد اسبوع مثلا واشوف لو هي كل حاجه كويسه ممكن تبقى انديوز عادي.
هي فول تيرم وكان انديوز ليبر. If full term you can induce labor, we can terminate pregnancy.
It's
Full term.
actually a point of controversy, especially if you didn't find any cause. But you need to be you need to do assessment, proper assessment. Exclude rupture of membrane, exclude IGR, exclude congenital malformations. Ensure fetal well-being. Okay. See if the fetal fix is satisfactory or not. Okay. And at the end of the day, if you don't find any cause, you can repeat your assessment again. You repeat the scan again, especially after telling the woman to drink a lot, because there is a relation. There is a relation between hydration status and the amount of fluid of the amniotic fluid. So this can be an advice if you didn't find any cause, and you can actually at the end, if you find the cervix is soft and can be induced easily, and with proper counseling of the woman, we can induce her. But this is the last thing to consider, and it's more important to assist the patient than to go into induction straightforward.
يعني الماتيرنال هايدريشن ممكن يفرق ويحسن الامنيوتيك فلويد؟
Yes.
هو مش الفيتاس والمين كونتريبيوتر؟
اي في.
Advise the woman to drink a lot, especially if you are in hot countries. When the mother is well hydrated, there is more water is going to the baby. More there is exchange between the mother and the fetus in the fluid. Okay, not for cells, for fluid there is exchange. Okay, and yes.
Just non-stress test for fetal well-being in case of oligohydramnios. Fetal well-being.
Yes. Yes. CTG. Okay. You can find some association that can justify your induction, like having persistent decreased fetal kicks, okay, or there is a small fulgurational age, for example. You can find some other associations that can initiate your or can push you to induce her, okay. And for practical speaking, also counseling of the patient is very important in this issue. Also, you will not make judgment about the amniotic fluid index in cases of unexplained oligohydramnios from one time. You need to repeat the scan more than one time. Okay. And
for a big scan after a week.
Also, there is no guideline, but you, according to the amount of liquid, according to the case, if it's just 4 centimeters, okay, and her fetal kicks is okay, and the patient is aware of her fetal kicks, okay, you may give her, and she is, for example, 37 weeks, you can give her 1 week, no problem, okay. But if she is 41 weeks, or she is 41 weeks, for example, I think it's better to induce her. So the gestational age also can make difference in the match. Regarding
But can we make a decision of cesarean section for decrease the milk index, fluid index?
no. Polyhydramnios is diagnosed if the amniotic fluid index is more than the 95th percentile, which is either in practically amniotic fluid index more than 25 centimeter, or the deepest vertical ball is more than 8 centimeter. Its incidence, it can vary from 0.4 to 1.4. Many causes, but you can find that the idiopathic cause is on the top of the list. Then it can be maternal or fetal or placenta. The fetal causes can vary. It can be twin-to-twin transfusion, yes, or GIT anomalies. GIT anomalies,
esophageal atresia.
yes.
اسوفيجيال اتريدي.
What else?
Jidden atresia.
Can imperforate anus cause? Can imperforate anus cause polyhydramnios?
No.
No.
Why?
نو 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 نو. لان بيحصل swallowing عادي وابزوربشن للفلويد.
Yes. So obstruction in large colon may not be cause even polyhydramnios. Obstruction of small intestine or stomach or esophagus can cause polyhydramnios. Also, neuromuscular abnormalities or CNS abnormalities, because there is a defect in swallowing.
Swallowing.
Yes, some congenital heart anomalies that also can cause cardiomegaly and affect the swallowing. Some infections, like parvovirus, which cause fetal anemia.
Hydrops.
Yes, chromosomal abnormalities can be a
Random hydrops.
Okay, so many fetal cause. Maternal cause, poorly controlled diabetes, and also renal failure. Why renal failure can cause polyhydramnios? Why diabetes can cause polyhydramnios? When it is uncontrolled, because the glucose or urea will pass through to the baby. According to
large
concentration.
Increase plasma osmolarity. Plasma osmolarity will increase.
Okay, so it will go to the baby and will go to the kidneys of the baby and will shift out the fluid into the amniotic fluid. Okay. Placental causes, rare tumor which is called
Chorioangioma.
معلش يا دكتور لو سمحت ليه الرينال فيلير بيعمل؟
also because of urea. There is a increased level of urea that can cross the placenta also and causes shift of fluid from the same as glucose. Okay. Complications, many complications, and the most important for it is preterm labor. These complications can occur even with idiopathic polyhydramnios. So without even having additional cause, these can be a complication. Polyhydramnios can cause preterm labor, rupture of the membranes, abruptio placentae, malpresentation, cord collapse, cesarean delivery, postpartum hemorrhage, and also there is with perinatal mortality rate. It doubles the perinatal mortality. There are two types of polyhydramnios actually. We can rarely see acute type, which you can see a rapid accumulation of amniotic fluid and severe abdominal enlargement, edema of the abdomen, and this most probably ends with a preterm labor. Okay.
هو الاكيوت في حالات التوين تو توين ترانسفيوجن اونلي يا دكتور ولا ممكن في حالات تانية؟
Mostly in twin to twin transfusion, but يعني can rarely happen with another cases. يعني you will find a strange case every now and then like this. Have you ever seen acute polyhydramnios? Anyone have anyone have ever?
Yes, uncontrolled diabetes sometimes discovered with acute polyhydramnios.
Yes, and when you
rapid no.
when you do control, you find a sudden reverse
Improve.
of life.
Improve, yes.
Yani actually, from clinical point of view, sometimes you may diagnose diabetes, you may suspect diabetes when you find a woman with
polyhydramnios, yes. Polyhydramnios.
You will do oral glucose tolerance test. You find a high number of or values of glucose. When you control the condition, and how can you control diabetes, gestational diabetes with polyhydramnios?
Medication or insulin. Medication, mostly insulin.
Medication and insulin.
Don't try diet. You
will tell her diet advice, but it's important to give her medication, especially insulin. Okay. Chronic, more or less, and it can also do symptoms, but it can take some time to present with symptoms. So clinical pictures for the cause, and actually, usually it can be accidental discovery sometimes, or you will find maternal symptoms like having abdominal enlargement, stressing symptoms, or it can be with the follow-up. In a low-risk woman, the midwife finds the symphysiofundal height is higher than the expected gestation, and it can be present with the complication like preterm labor or antepartum hemorrhage or collapse. Now, what are the recommended investigations for a case with a low-risk woman, primary gravid at 32 weeks, referred from the midwife because of the symphysiofundal height is large for her date, and when you do abdominal palpation, you cannot feel the fetal parts. What will you do for her? Okay, you diagnose clinically that she is most probably having polyhydramnios. What is your assessment?
Should confirm with ultrasound. I'm measuring deepest vertical box.
You find the deepest vertical pool is 10 centimeters. What
I will start with GTT.
10 centimeters. It's okay. No.
Yeah.
10 centimeters. The polyhydramnios.
You will
start with GTT number 1.
With what?
Check the blood sugar.
Blood sugar, yes.
Blood sugar, yes.
We'll investigate diabetes. What else?
Congenital anomalies.
Yes, you will search.
Still the ultrasound anomaly scan.
Yes, you will do anatomy scan. Okay.
Exclude infection.
infection screen.
Yes, you can exclude.
maternal anemia.
Fetal anemia. Yes. Okay.
Hemoglobin especially.
Okay. What else?
Why anemia, doctor?
It can be polyhydramnios can be associated with hydrops. So you may find with polyhydramnios hydrops.
RH.
And at this case, you need to do investigations for hydrops that can be immune, non-immune, whatever. So it can be a part of screening or
fetal anemia cause heart failure.
yes.
Maternal anemia.
Fetal anemia.
Oh, okay. Fetal.
It can be a part of or associated with hydrops. So if it's associated with hydrops, you will do all of things that can be done in hydropic cases. Okay, and don't forget to do postnatal evaluation, even if you don't find any cause during the antenatal care, because idiopathic polyhydramnios can have hidden congenital anomaly. Okay.
Yes.
And yes, and according to the case, you can need to have chromosome. This is not routine for all cases, but according to the case, if you find stigma for chromosomal abnormality, you need to offer. If you find other signs of congenital infection, you need to do so. It can be from one case to another. Okay. So the management of polyhydramnios. Antenatal. What do you need to do antenatal?
According to the cause of the polyhydramnios. The patient is
The cause, and if we are dealing with idiopathic, for example, and you find that there is maternal pressure symptoms like having dyspnea, like orthopnea. Okay.
amnio reduction.
You need to
Amnio reduction.
according to the severity of symptoms, according to the if we have a reversible cause or not for diabetes, we can control if diabetes can control the condition. For example, for other causes, we may not be able to control the condition, so we need to for example, to tell her how can she relieve the symptoms, the way of lying. For example, we can give her non-steroidal anti-inflammatory medications, but for who are less than 30 weeks or 28 weeks, and not longer than 1 week. Okay. And we can offer amnio reduction, but this procedure can be repeated many times. Okay, and if you are going to do amnio reduction, this is a chance to do chromosomal study if it's indicated to do chromosomal study. Okay, so this can be done antenatal to relieve her symptoms. Okay.
Can we give drugs that decrease the amount of amniotic fluid?
Yes, it's only non-steroidal. Do you know another medication, for example?
Yes.
What else?
No. I ask about non-steroidal.
What I know, yes, I told you non-steroidal. Okay, and we can also, if she is in preterm labor, we can give glucolysis and steroids if indicated. and it's important according to the amount of polyhydramnios we can offer hospitalization, especially if there is a severe polyhydramnios that can, if there is sudden rupture of membrane, can cause abrupt placenta, for example, or there will be a cord prolapse. Okay, so this is an indication to hospitalize her. Okay. And if there is a maternal distress after 37 to 38, you need to consider delivery, not to do an amnion reduction again. Okay. And I am sure that you are know all the side effects of non-steroidal, and the most common medication used for polyhydramnios is indomethacin. Okay. This for reductive amniocentesis also. For the intrapartum care, is it different than the usual care, or it is the same as usual care?
Yes, during the rupture of membrane, we need the controlled rupture of membrane.
What's controlled?
Gradual release of amniotic fluid.
Using needle.
To prevent cord prolapse.
And sudden decompression and separation of placenta, abrupt placenta.
Yes, yes.
Usually, we do rupture of membrane routine during labor.
No.
Yani you will not go to rupture of membrane, especially if there is the degree or a high degree of polyhydramnios. Okay, because this can be dangerous during labor. Actually, if you need to decrease the amount during vaginal birth, you may do amniocentesis, not to do rupture of membrane if you are afraid to have rupture of membrane. So you can do amniocentesis while she is in labor, or you may go to do cesarean section actually if you have unstable lie, or the condition if there is cord presentation, or you are afraid. So you can do a cesarean section for some cases actually. Okay. You need to individualize your management, but generally this case is liable for cord prolapse, so you should be vigilant to detect cord prolapse and uterine inertia. So if there is a spontaneous rupture of membrane happens while she is in labor, you need to examine her immediately and to check the to put her on continuous electronic fetal monitoring while she is in labor. Okay. If there is third or fourth, during you need to have to
active
yes, active third stage. You need to monitor her
observation
in the third and fourth stage. Okay. And the baby should be evaluated for congenital malformation. Sometimes you need to induce her, especially if there is associated medical condition like diabetes. If there is unstable life.
Induction.
Yes, and it can be done concomitant with amnion reduction. So you can do amnion reduction while the baby is cephalic and then go directly to induce her, for example. Or if there is a specific congenital malformation and you need to do elective delivery, okay, or there is a maternal distress. And cesarean section can be done for obstetric indication like having malpresentation, cord presentation, many associated conditions, macrosomic baby with diabetes, so you can offer a cesarean section. Okay. Now we will go to decreased fetal movement, the next topic. In the beginning, we need to agree what is the fetal movement. Is it fixed time, fixed number of movements at a specific time, or how can we describe for the woman, or how can the woman describes it for us? Any suggestions? No. Fetal movements or perceived fetal movements are defined as maternal sensation of any discrete kick, flutter, swish, roll, anything related to the baby, any movement related to the baby, and it has a relevance to we need this to explain to the mother that this movement means the integrity of CNS and the musculoskeletal system. Okay, so it's a reassuring sign, and it can be detected by most of mothers between 18 and 20 weeks. For sure, it can be detected for multiparous earlier than primary gravity. Okay, so its importance that it means there is the baby is living and the baby is good actually. When the mother is perceiving a satisfactory movement from the baby. And reducing or absent fetal movements may be a warning sign of impending fetal death. Okay. However, the majority of women, 55% experiencing a stillbirth perceived a reduction in fetal movement prior to diagnosis. Okay, so 55% of stillbirth cases were perceived by a decrease in the perception of fetal movement. So you need to take it seriously. Okay. However, you need to there is a procedure before going or telling that it's and there is it can be. We need to understand also that sometimes the mother is not aware of the fetal movement. So there is a way of maternal perception. So it can differ. This symptom can differ from one to one according to if she is not already. She may not feel the fetal movement at all. And you asked her now that do you feel the fetal movement? No, I cannot feel it. Okay, she cannot feel it from the start of pregnancy or from the 20 weeks. So you cannot make a judgment directly on her feeling. Okay. What are the causes of decreased fetal movement? For sure, stillbirth can be a cause, but what else?
Placenta insufficiency.
It can be physiological fetal sleep. Fetal sleep. What is the difference between the character of decreased fetal movement or fetal movement from intrauterine fetal death to fetal sleep? Fetal sleep, it will be temporary, but intrauterine fetal death, it will be permanent. So you need to, when a patient comes to you telling you there is a decreased fetal movement, absent fetal movement, you need to ask about the time, the duration, okay? Some congenital malformations, and for this cause, it can be a decreased from early time of pregnancy, okay? Fetal anemia or hydrops. Also, hypoxia can be a cause because when the baby does not have an adequate amount of oxygen, he will try to preserve his energy. He will try to not to move because movement will consume more oxygen and will consume more glucose. So he will try to preserve his energy. Okay, sometimes feto-maternal hemorrhage, polyhydramnios, maternal weight sometimes, placental location. Anterior placenta can also cause decreased perception of fetal movement because when the baby kicks the placenta, the mother will not feel it. Some sedating medications, okay, like alcohol, benzodiazepines, even smoking, corticosteroids, and I think all obstetricians and all of you have noticed that when you give to the woman corticosteroids, in the next 2 days, many women complain of decreased fetal movement. A busy mother who is not concentrating on fetal movement, maternal anemia, metabolic disorders, hypothyroidism. Okay? So, how can you assess the fetal movement? How can you assess the fetal movement? Would you give the woman a paper or a chart for fetal kick chart? This was done in the past. Actually, when I started my life as a registrar, there was a chart, count to 10 chart, okay? And this proved to be not beneficial. We need to depend on subjective maternal perception of fetal movement and no formal fetal movement counting using specific alarm limit. And every woman should be aware of his or of her baby's individual pattern of movement. So I am trying to tell the woman, this is your son. You need to be aware of him. Okay? And no one will be aware like you because he is part of you. And you need to feel if he is moving well or not. So she needs to develop this sensation. Okay? Clinicians should be aware that instructing women to monitor fetal movement is potentially associated with maternal anxiety. And if you are trying to make a lot of stress on the fetal movement, this can make her an anxiety. So it is one part of antenatal care, but not not try to make the patient anxious. You can with when you are talking a lot about fetal movement, she may not feel. She may be hesitating. What's fetal movement? I may not feel it well. So don't instruct her to monitor the fetal movement. Usually fetal movements are usually perceived by 20 weeks and tends to plateau at 32 weeks of gestation. There is no reduction in the frequency of fetal movement in the late third trimester. Women should be advised of the need to be aware of fetal movements up to and including the onset of labor, and should report any decrease or cessation of fetal movement through their maternity unit. Okay. Now, what are the abnormal fetal movements, and what is the management? Okay, if there is a reduced fetal movement after 28 weeks of gestation, what will you do? What is the advice for her? If a woman, yes, if a woman is concerned, you need to go systematic. Okay, you need first to assist.
Advise her to contact her maternity unit on the same day.
Yes, and most women will not go to the hospital directly and to a facility with ultrasound. So if a woman is concerned about reduction in fetal movement, presents to the community setting, this is the most common presentation with no facility to auscultate.
Auscultate by handheld.
Okay.
Handheld Doppler.
Yes. She should be referred immediately to her maternity unit for auscultation and should not wait until the next day. And you need to do assessment, including history, examination, investigation. And the important points in the history are the points which, the same points for IGR risk. Okay? And also it is the same points for stillbirth risk. So you need to do what's called comprehensive stillbirth risk evaluation. Okay? Multiple consultation for reduced fetal movement. When you find there is many presentations, this is you need to feel the risk and to do with the patient as there may be a risk for her. If there is IGR, hypertension, diabetes, smoking, all of these factors can be risk for IGR, congenital malformations also. If women are unsure whether movement are reduced or not, you need to advise her to lie on the left side and to give her the chance to focus on fetal movement for the coming 2 hours. And if they don't feel 10 or more discrete movement in 2 hours, they should contact their midwife or maternity unit immediately. You will tell me, so I will take this as the baby needs to move 5 movement in each hour. Okay, or actually most of babies move more than that, and not every movement of the baby the woman can feel or can count. But here you make the patient in an concentrated situation. She is not concerning with anything except what is in her abdomen. So this is the minimum amount of movement when she is completely concentrating with the baby, and she is lying on her left side, so any movement can be felt easily.
دكتور احمد، يعني دي الحاله الوحيده اللي بيخليها تركز انها تعمل كاونتنج، انها انشور.
بمعنى if she is she is sure، يعني ما هو لا اما البيبي بيتحرك لا اما البيبي ما بيتحركش. لو ما بيتحركش انت متاكده ان البيبي ما بيتحركش، بتقول لك يعني بيلعب بس مش اللعب اللي هو بيلعبه زي الاول. تمام؟ ممكن ان احنا هنا نديها فرصه ان هي ايه، ان هي
شور،
يعني ان هي
كونسنتريت في دمه.
بيشور يعني بيشور.
لو هي بتقول لك لا البيبي ما بيتحركش خالص، لا دي قصة تانية.
خليها تعمل كاونتنج صح؟
لا لو هي بتقول لك البيبي ما بيتحركش خالص، لا اول حاجة محتاجين
maternity run to shake fetal heart. shake fetal heart.
نسمع البيبي وبعدين نشوف بقى هنعمل ايه، اللي هو زي ما انت بتقول كده ان احنا هنعمل سي تي جي الترا، هنشوف clinical examination measure blood pressure اوكي fetal size ده after ايه after operating the baby. تمام. actions you ensure that the baby is living. What will you do? Sometimes when after while you are doing your assessment, the patient will tell you the baby now is moving well. Okay. So she can be reassured if after discussion the woman does not have reduced fetal movement and there are no other risk factors for stillbirth and there is the presence of fetal heart rate on sculpture. But you can do further investigation, and the most important thing is to do CTG or non-stress test. Okay, for women noticing a sudden change in fetal activity or in who mother risk factors for stillbirth identified, or the woman still her concerns. Okay, so if you find that a woman is persisting on the absence or the change in the fetal activity, or even if started to be reassured or she feels now it's started to move, but you have some or you have many risks for fetal for stillbirth. So we need to have a confirmatory test which is non-stress test. Okay. And CTG should be arranged to exclude fetal compromise if the pregnancy is over 28 weeks, and CTG monitoring of fetal heart rate initially for at least 20 minutes. Okay, and it should be done in the left lateral position, and we need to we will not accept any abnormality. Okay, because this is not intrapartum. We will not accept any deceleration. Okay, we need to have acceleration. We need to have adequate variability. Okay, so every point should be normal. Yes, for sure, as it's written in the small positional age, that computerized CTG is better, but actually computerized CTG is not present in each labor ward or in each antenatal or in a hospital in each hospital in UK. So we are still can interpret the CTG by ourselves, because there are computerized CTG, it's a machine that interprets CTG for all, it has its interpretation, and it depends more on the variability more than, it's considered as the best parameter to do an action on its abnormality. Okay. Ultrasound assessment. Sometimes we may need to do ultrasound, especially if you find after the CTG, the normal CTG, that there is still reduced fetal movement, or if there is additional risk factor for fetal growth restriction or stillbirth. And it should be performed when the service is next available, performed within 24 hours. So first to be done is CTG, then the ultrasound. And we need to check in ultrasound the growth of the baby and the amniotic fluid, and also to ensure the fetal morphology, because the decrease in fetal movement can be due to a fetal abnormality. Okay. Biophysical profile is not recommended to be done, because the systematic review concluded that available evidence from randomized controlled trials does not support the use of biophysical profile as a test of fetal well-being in high-risk pregnancies. However, we have some evidence that from observational studies that it has a good negative predictive value. This means that if you find that the biophysical profile is good and there is no abnormality of the baby, most probably there is no problem. The problem that you can find it abnormal, and the baby may not have a problem. Okay, but it is not usually used in UK anymore. I know most of you know the score, and it's not important for the exam. If you find that all the investigations are normal, we need to reassure the woman, because 70% of pregnancies with a single episode of reduced fetal movement are uncomplicated, so there is no problem anymore. And women should be advised to contact their maternity unit if they have another episode of reduced fetal movement. But if we have recurrent reduced fetal movement, we need to put in our minds that this is associated with a poor neonatal outcome. Okay, or there is there is an increased risk of poor neonatal outcome, and if she didn't have a scan, we need to do a scan for her, and according to her gestational age, to if there is associated IGR, if there is associated oligohydramnios, if there is the CTG shows any problem, we need to consider to do the management, which can be delivery sometimes. So especially if it is at term, so we can individualize it according to the association. Okay, I know this is a gray area in obstetrics, like management of oligohydramnios at term. Okay, but if there is a recurrent reduced fetal movement at term, put in your mind that we can deliver here. Okay, after having a discussion and individualized management. And this is a nice chart for a flow chart. What can you do for decreased fetal movement? So you will begin with a history, and if you confirm that there is a reduced fetal movement, you need to auscultate. If you don't find fetal movement, you need to do ultrasound. If you diagnose the intrauterine fetal death, this is the management of intrauterine fetal death we will discuss now. If this fetal heart rate is auscultated, you need to do CTG, and according to the CTG, if there is a suspicious or pathological trace, most probably you need to deliver here. If it's normal, you need to, according to the presence of IGR risk factors or stillbirth risk factors. If it's present, you need to do ultrasound. If not present, you need to reassure the woman. If there is a recurrent, you need to do more frequent assessment, and according to the gestational age, the associated gross restriction, liquor volume, many things you can offer here at the left. Okay. Any questions?
يعني دكتور احمد كان في سؤال كده واختلفنا عليه، اللي هو حاله 38 اسبوع ومفيش اي ريسك فاكتور، البريجنسي كان ان ايفنتفول وجايه بسكند ايبيزود اوف ريديوسد فيتال موفمنت. البيست اوبشن بالنسبه لي ان انا اعمل لها الترا ساوند سكان واعمل لها رياشورنس، ولا ان انا اعمل لها اندكشن اوف ليبر في 38 اسبوع.
induction of labor.
ونان ليبرتي.
اوكي.
induction of labor.
اول حاجه يعني الريكارنت دي قلنا associated او ممكن يبقى فيها مور ايه مور ريسك. الحاجه الثانيه هي اكيد عملت الترا ساوند سكان. الالترا ساوند سكان مش هنعمل لها الترا ساوند سكان جديده، ما هي ما دام ريكارنت يبقى عملت سكان. تمام؟ او لو هو قال ان هي عملت سكان يبقى مش المانجمنت ان انا اعمل سكان.
لا مش قايل ان هي عملت سكان. لا
الحاله اللي زي كده يعني بالكلام بتاعنا مش شايف السؤال، لكن بالحاله اللي انت بتتكلمني عليها دي انا هبقى اميل ان انا اعمل لها اوفر هير اندكشن اوف ليبر، اوفر واقول لها البروز اند كونز بتاع الاندكشن اوف ليبر. لو هي فعلا فيها بيرسيستنت ديكريس فيتال موفمنت مرتين او اكثر هاوفر هير الاندكشن. وهي 38 اسبوع عشان بس الناس ما تفتكرش اي عينه. لا وهي 38 اسبوع، لان هي الفكره هنا ايه؟ هو العينه دي لو انا مش هعمل لها اندكشن اوف ليبر وبعد وكل شويه بعمل لها سي بي جي، ايه اللي هيحصل؟ هعمل لها سي بي جي دلوقتي، طب هترجع البيت بعد 12 ساعه عندها برضو ما زال ديكريس فيتال كيكس، هتعمل لها سي بي جي تاني، طب وبعدين هترجع تاني هتعمل لها تالت، طب ما هي يعني وبرضو في حاجات كتيره بتبقى داخله معاها في الموضوع، يعني فحصها ايه اخبار. لكن هو طبعا في السؤال هو عاوز لك تختار حاجه من الحاجات اللي مديها لك، فعشان كده دايما يعني خليك بتفكر انديفيدوال. مش معنى ان انا قلت لك ان دي هتعمل لها اندكشن اوف ليبر ان هو الحاله اللي هتجي لك في الامتحان ان انت ممكن يغير في الكلام شويه فما يبقاش الوضع اندكشن اوف ليبر. واخد بالك؟
تمام.
بريك 5 دقايق ونكمل يا جماعه. السلام عليكم. بسم الله الرحمن الرحيم. نكمل ان شاء الله بأهم موضوع. It's more important than the previous two small topics. Intrauterine fetal death, and actually it's a catastrophe to have intrauterine fetal death. Catastrophe for the mother, catastrophe for the family, catastrophe even to the doctor. Very big load how to tell her, how to deal with her, and do we see cases with intrauterine fetal death, or you cannot hear me?
صوت بيقطع.
صوت بيقطع. طيب اكمل ولا اوقف ولا اعمل ايه؟ قولوا لي. اكمل ولا اوقف؟ اعمل ايه؟